Fine. Okay, so we're recording now. Brilliant. So let's start off. So yeah, we're recorded. We'll put it on YouTube on our channel, Quesmed Tutorial. So hopefully that's useful. And if you have any questions, please put it on the chat, and I'll try and get to it towards the end. Or if there's any sort of burning questions, I'll try and get to them between each question. Cool. So Quesmed is a question bank that we use thousands of questions, flashcards and notes and videos to help you excel at medical school. As you'll see from the questions that we have today, a lot of them try to push you a bit more than other questions, in the sense that they try and make you think laterally, think about the diagnosis, investigations and management, rather than just sort of factual repetition. So lots of people have said to us that this is sort of closer to the medical school exams, and also it helps them to think more like a doctor, which is what medical school should do. So we hope that these sort of questions are useful for you. For us, we have about 4,000 questions, 10,000 flashcards, and since lockdown we started doing SBA tutorials, which have been very popular. So we now have about 40 hours of free tutorials, that all the lectures and all the recordings are free. So if you go to Quesmed tutorials, you can view them all and whenever you like, and this one will be on there later. We're working on more stuff, so more questions. We're working on offline mobile app and PSA mock tests for those of you who are in your final year. If you want any uni-specific discount codes, please just contact us on either Instagram at Quesmed or on Facebook, or just email us. I'll send you my email as well at the end. So cool, yeah, that's us basically. Let me know if you have any questions. So today we will be going through single best answers in dermatology. We will be running through the most important core material that you will need to know as a medical student. And this involves, although we will be talking about single best answer questions, we will try and work on your spot diagnosis and your ability to interpret images. And equally, we will be focusing on sort of key buzzwords that you'll be expected to sort of recognize in your exam. The only thing we won't be covering, which is relevant to dermatology, is erythema nodosum and erythema multiforme, which is quite common and does come up in various clinical settings. So if you scan this QR code, you can go straight to our YouTube video about our previous rheumatology lecture, where we cover it in a bit more detail. So hopefully that sort of should, with that, if you wanted to check that out, will cover most of the dermatology you need. For most medical schools, dermatology comes in the form of written single best answer questions or different other types of written questions. And a lot of it is actually quite simple, to be fair, about diagnosis, investigations, and sort of not too complicated management, I think, on the most part. As long as you know the basics, usually you should be fine. And then when it comes to sort of oral or sort of OSCE exam style stuff, a lot of it actually tends to base around things like communication skills and sort of bits of factual knowledge in between. You may also be asked to sort of recognize images, and you get shown an image of a melanoma, for example, and you'll be asked, okay, what would you do next? So we'll try and cover that as well if you do have that in your oral exams. So it's useful. Good. So first question. So I'll give you about 50 seconds or so to go through. I'll time it, and then we will start there, basically. And we'll see if we can put a poll up as well. We'll try our best. Cool. So let's see if the poll, perhaps if it works, maybe you can try it out on the first question. Will it come up?
Do you need me to launch it?
Yeah.
Okay.
Grand. Sorry. Oh, do I just click? Oh, okay. I can click on it. Never mind. Yeah, my bad. Okay, so you just sort of, okay, I got it. I can probably do it next time. Thanks. Good. So we'll give you another sort of 10, 15 seconds, get all your answers in. I think we've got yeah, fine. Okay, most answers are in. Last few answers, please. Right, so in that poll, so most people have gone for D, and also people have gone for B. So potent topical corticosteroid B, and then potent topical corticosteroids and topical vitamin D. Good. So fine, thank you. So let's go to the answers. The answer is actually D, potent topical corticosteroid and topical vitamin D. So let's go through the question in a bit more detail. So you've got someone who's got a history of bipolar disorders, takes lithium, it's got a rash. Interestingly, the rash is on her knees, and it is an elevated irregular lesion that are red, well demarcated and scaly. So this is sort of the first instance where you sort of are looking at a question and you're thinking to yourself, what could this be? And the key buzzwords here are the fact that actually it's scaly, that's sort of the first one, and then also they're raised. So the raised lesions can be a lot of things, but if you've got a scaly red lesion, the sort of first thing you should be thinking about without anything else is actually going to be psoriasis. The next clue about whether or not this could be psoriasis is that she takes a medication called lithium, which is a sort of known precipitant of psoriasis. And of course, with this in mind, it could be other things, which we'll talk about in a bit more detail, such as Lichen Planus, for example, which maybe are sort of a bit more purplish rather than red, and not so scaly as well. But in this particular scenario, the single best answer, as it were, is going to be psoriasis. And it is an inflammatory condition that we try and treat by dampening down the immune system. And it is sort of a relatively sort of difficult to treat with simple steroids. So we tend to give potent topical corticosteroids, and that tends to also give topical vitamin D. I won't go into this in too much detail just yet, because we'll talk about the management of psoriasis in terms of how it looks like in a stepwise progression in a few more slides, so that you can sort of get the big picture rather than just me talking about each bits and bobs. Okay. So let's move on. Next question. So the way to sort of remember the potency of topical steroids, and this is useful in clinical practice and also in your exams as well. This is a mnemonic which is help every budding dermatologist, and it sort of lists all the potencies of different corticosteroids. These are what you would give on people's skin, and on the most part, sort of the milder corticosteroids that you can give, those are the ones for sort of less severe reactions, whereas the very potent ones you may use for sort of more inflammatory disorders that are very severe. So it sort of makes sense. So hydrocortisone start off with Umivate, Betinivate, and Dermavate. To be honest, personally, I've only ever prescribed hydrocortisone. I'm sure in dermatologists, especially for patients with severe disease, they would go up on the stronger stuff. But it's just a useful mnemonic. You don't need to know too much detail as a medical student, but it's good to have ability to recognize which is strong and which isn't. So psoriasis, it's an inflammatory condition, and it sort of is related to this proliferation of keratinocytes, and you get this sort of well-circumscribed erythematous, so red plaques, as we said earlier, and it tends to be on extensor surfaces rather than flexor surfaces. So things like the elbow, things like on top of the knee itself, which is what we had in our patients. And there is a particular phenomenon called the Koebner phenomenon, which is a phenomenon that actually happens in a lot of skin conditions, but it is well associated with psoriasis. And that essentially is when you have a scar on any parts of the body, and you can sort of get psoriasis around that scar in itself. And that is called, or sort of this red scaly lesion that sort of accumulates around that scar. And that's called Koebner phenomenon. Obviously, with any skin disorder, you have a differential diagnosis. So tinea corporis, which is sort of a fungal infection, that also has a bit of flaking and scale and can be commonly affected, commonly sort of recognized, similar looking to psoriasis, but perhaps it may not be sort of so widespread. Maybe it's sort of only in one area that is affected. Eczema as well, but eczema tends to more affect the flexural surfaces. You get lichen planus, which we'll talk about, and then psoriasis, rosea. We will talk about that in a bit more detail shortly, so that you can recognize the differences between them. So we talked about skin trauma as a trigger, but also you can get different infections and drugs. So lithium was the one we mentioned, but also beta blockers, antimalarials, and also some non-steroidal anti-inflammatory drugs. Otherwise, in terms of your lifestyle, things like stress, alcohol and smoking, and the cold and dry weather can also lead to triggers of and worsening of your psoriasis. There is also this picture here, as you can see. So if I was to describe it, you can see the sort of mobiliform, sort of red, scaly lesions throughout the chest. And although this can look like something else, which we'll talk about later, in this particular scenario, this is known as guttate psoriasis, where you have psoriasis that looks like small sort of dots throughout the body. And the distinguishing factor tends to be the fact that it's quite scaly, more so than other conditions that look like it, which we'll talk about in a second. And yeah, so know that guttate psoriasis is one form of psoriasis that we commonly see. As for the treatment, so you start off, as with most of dermatology, in preventative treatments where you avoid irritants. So lots of soaps and perfumes can irritate psoriasis, so try and use things that are less scented, for example. Equally with soap substitutes like certain aqueous creams. The sort of mainstay of most dermatological treatments, which should be your answer in any OSCE scenario, is going to be give lots and lots of emollients, which try and moisturize the skin, so even up to 4 times a day. And you can use things like dipper base, which depends on which trust you're in, but you can use anything essentially to moisturize the skin. And then topical treatments, and again you can see the stepwise progression where you talk about emollients, then you talk topical, then you talk about your sort of oral stuff, and then you give vitamin D analogs, such as the ones written here, and steroids as well. And you can sort of use quite a lot of different drugs, and really the idea is that you're trying to dampen down the immune system, and these are all options that have different mechanisms that dampen down the immune systems. So coal tar is one of them, interestingly, and I understand from lots of from dermatologists they don't use it so much because it's quite messy apparently, so patients don't like it very much. But there are many options in terms of topical. And then as you progress in your treatments, you can also give phototherapy. You can give oral medications such as acetylretinoin, cyclosporin, and methotrexate, again immunosuppressants, and have their own side effect profiles beyond the scope of this lecture, and also biologic therapy, so anti-TNF drugs such as etanercept and infliximab. So again, with all these drugs, there are risks and there are benefits, so you need to explore them with the patient. I think in our rheumatology lecture that we had earlier, I talked about rheumatology drugs in a bit more detail, so you can have a look at that for a bit more of a wider scope of sort of drugs used in rheumatological conditions, which always has some overlap with dermatology. Cool. All right, let's have a look at the next question. Right, so I'll give you the polls and relaunch. Yeah, let's do that. Good. Let's put people's answer in as and when. Good. So let's see what people think. So put all your answers in, please, as you can. And then we'll get to the end. So last few answers. Good. Okay. So that's fine. So in that poll. And then everyone can see that, I think. If you can. Yeah, fine. So you're now viewing the poll results. Good. So I think 45% have gone for B, and then 28% have gone for C. Cool. Very good. So we're going to away. Good. So the answer here is reassure and discharge. So again, this is sort of something I alluded to earlier. This is a 17-year-old boy who's had a cold over the past few days. And then generally speaking, when someone has a cold and a skin reaction, you probably think that they are related to some degree. That's sort of the biggest point from this question, at least. And equally, this is true for lots of other things, such as rheumatological conditions, cold, and then something rheumatological. They tend to be related. Equally, neurological, cold, neurology, for example, Guillain-Barré, or if they have gastroenteritis, neurological syndrome, again, Guillain-Barré. So 3 centimeter discoid patch that is red and scaly. Again, so if we were to think about psoriasis, that's also red and scaly, but equally the particular pattern we have is you've got a discoid patch, which is just one patch, and then you get smaller lesions over the chest and back, and then after a day, there's more lesions after the initial patch, and then they're not itchy or painful. So this is most likely to be a condition called psoriasis rosea, which I'll show in the next slide. And this is a sort of self-limiting condition that requires no treatment. It looks a bit like psoriasis, but the difference is that you have one patch and then it becomes small, lots of other smaller lesions. And there's no real treatment. You just reassure and you discharge. So let's look at some more pictures of it, because that is what you see. So you can see here that you got this sort of small patch here, which is what we call the Herald patch, large discoid erythematous patch, and then a few days later you get all these small little dots there that are also a bit scaly, and the lesions are classically distributed in a Christmas tree pattern, which I'll show you in the next slide. And that's a sort of another buzzword, but most exam questions will not tell you that it is in a Christmas tree pattern, but you can sort of figure out if you look at the picture. And again, it's self-limiting, it's benign. The mechanism isn't really well known, but it just happens to happen after an upper respiratory tract infection. So I suppose you could argue that this looks like a Christmas tree, maybe. It's like this is the bit of the Christmas tree at the top, and then the bottom, I guess. But you're just going to have to go with it and just say that it's probably worse at the bottom and then less at the top. So that's how it looks like a Christmas tree. But if you have any other pictures, do share them with me so I can add them to this presentation. But I think it's the best that I found, at least online. So yeah, that's it. Psoriasis rosea. Cool. Right, next question. Right, so now that we got that, let's do a poll. Good, let's see what people think. Mm-hmm. Okay, cool. So let's see what people think. So end that poll and share the results with you. Okay, so 66% have gone for B, which is staphylococcal infection, and then 17% have gone for A. Those are the sort of most significant ones. That's fine. Stop sharing there. So the answer, in fact, is atopic dermatitis, also known as eczema, which is really good, actually. That's why most people have gone for B, because it allows us to sort of deal with some common misconceptions about sort of whole body rashes, which is, I suppose, these whole body rashes are the sort of true dermatological emergencies that, at least from my experience, are the only reasons to get a dermatologist out of bed on a Sunday morning. So certainly they're useful for you to know, because those are the ones that you'll see most likely, even though they're quite common, but the most likely, at least in a more emergency setting when you're a junior doctor. So let's just stop sharing that. Okay, that's cool. So so they've got a severe rash, and there's whole body erythema of the skin, affecting more than 90% of the body surface. The skin is warm to the touch, and the patient is shivering, complaining of being cold. Blood pressure is a bit low, heart rate is high-ish, and then there is, you're talking about the underlying cause. So I think what most of you possibly have gone for, that this is most likely to be the TEN, or toxic epidermal necrolysis, which sort of comes hand in hand with sort of Stevens-Johnson syndrome type stuff, which in that case, you may be thinking of staphylococcal infection sort of leading to this staphylococcal sort of scalded skin syndrome, which is a fair estimate in the sense, but actually looking at this question, there's no sort of talk about any desquamation of the sort of skin coming out of be peeling itself. That's more likely to be this 10 type picture. This is actually erythroderma, which is where you just have the whole body is red. And atopic dermatitis, eczema, is one of the most common causes of erythroderma. So let's try and distinguish between these two conditions so you can hone down on how you differentiate between them. So erythroderma is a dermatological emergency, which is where you have essentially redness of the skin all over. And it can lead to quite severe illness, and you may need to give lots and lots of fluids and do a full ABCDE assessment to make sure that you are on top of their fluid losses. The causes are eczema, psoriasis, and also can be drug induced. And many different drugs can cause it. It's not so worth, as it were, learning which ones do, but it can be drug induced. So it's very important for you to take a very good drug history in any dermatological case anyways. You stop any offending drugs for taking it if you're concerned about it, and then you would essentially give them loads and loads of sort of wax coating throughout the body to try and reduce the amount of loss of fluid through the skin and try and sort of maintain their moisture. You can also give topical drugs, so this is topical corticosteroids, topical, not tropical, and then that can help sort of reduce the inflammation. And if it's very severe, I've seen it at least once, you can give oral steroids. And you really, as an acute medical doctor, if you are an acute medical doctor at the time when you see it, which I was and am, then you would watch for any fluid loss. So give them lots of fluids, watch their renal function, watch their sort of sodium, potassium, magnesium, phosphate, because they might lose it, and then make sure that if they're hypothermic, you can either give them warmed fluids, for example, or you can put them on a bear hugger, which sort of tries to warm them up. And they are, of course, at higher risk of infection, so you would swab them for bacteriology and virology to look for any evidence of any overlying infection, which can make things worse, obviously. So that's important. So that's erythroderma in a nutshell. And this is sort of the thing perhaps some of you might have been thinking about in a bit more detail. This is sort of we would normally call sort of Stevens-Johnson syndrome, which exists in a bit of a spectrum with toxic epidermal necrolysis. So you can say that sort of the worst aspect of toxic epidermal necrolysis, of Stevens-Johnson syndrome is TEN. And what you get is this sort of widespread desquamating rash where your skin starts peeling itself, and also you get this mucosal involvement in most times, and that can also you need to sort of look out for any overlying infection in this group of patients as well. So it is also sort of mainly caused by drugs, and again, it can be anything from antibiotics, it can be loads of different antibiotics, it can be something like protein pump inhibitors, and there's a very, very long list, so if you're interested, you can have a look at it. I won't talk about it too much detail now, and again, generally the management is supportive, and you could consider steroids and immune agents if things are not going too well. So I guess this is sort of can be in keeping with this kind of staphylococcal scalded skin syndrome. But again, just to make the point that Stevens-Johnson syndrome and erythroderma, two separate things, and can be caused by different disorders. So erythroderma is more likely to be psoriasis, and eczema can be drug related, whereas this one is more likely to be drug related, although it can, I suppose it can just be idiopathic. So that's just a general view of these big emergencies you should definitely know about as part of dermatology. Cool, let's have a look at the next question. Cool, right. Let's get a poll in, see what people think. Okay, what do people think? This question. Okay, good, good. Most people in. Yeah, if you just give us yeah, another sort of 5-10 seconds. Good. Okay, that's fine. So, in that poll, so 64% have gone for B, and then 21% have gone for C. Okay, so that's good. Side, and then yeah, so the answer is lichen planus, which most people have gone for. It's very good. So got a rash in a 28-year-old man. He's got a burning sensation in his mouth on eating. Number of irregular purple plaques on the palmar aspect of the wrist covered by lacy white lines. So this is sort of a pathognomonic, as it were, of lichen planus, which sort of indicates to you that it's the big sort of features are the fact that he's got purple plaques rather than red, palm aspect of the wrist as well, rather than sort of on the extensor aspect. And there's some lacy white lines. And equally, there's some issues in his mouth, which you can have some mouth involvement in lichen planus as well. Let's just go through what lichen planus is. So it's sort of, again, to a certain extent, an inflammatory reaction where there is obviously a genetic element, as most things in terms of skin do have, but actually it's mainly characterized by the 6 Ps, which are purple, pruritic, itchy, polygonal, so it can affect multiple sides of the body, and also it's planar, sort of flat top rather than sort of raised, and you can have plaques. You can also have papules as well, so it can show up in different ways. But the main ones, I think, is the sort of purple aspect and the fact it's very, very itchy. The other features, Wickham striae, so you get these sort of white changes in the mouth. I'll show you a picture on the next slide. And also it can be on the flexor aspects of the wrist and on the ankles. Importantly, the psoriasis, which is one of the main differentials, is mainly on the sort of extensor surfaces. So this is an important distinction in your exams and in real life. And you get this Wickham striae, which is a sort of reticular white sort of pattern on the gums and the tongue, which I'll show you in the next slide. Yeah, so there, so you can sort of see that white, these white bits, Wickham striae, which are associated with lichen planus. So those are the sort of clues that would probably push you towards this diagnosis. Okay, next question. Right, so let's give you a poll. Good. Okay. Right, give you 5 more seconds. I think most people have gone in, I think. It's a tricky one, this one, I think, because it requires a bit of background knowledge. But these are the sort of questions that actually do come up, so it's good to know. Good. Okay, we're just going to stop there and see what people think and end that poll. So I think 50% have gone for A, and then, oh, sorry, no one can see it. 50% have gone for A, 34% have gone for D, and then 13% have gone for E. So it's fine. Tricky question. And then let's just have a look at the answer. Cool. So the actual answer is Pemphigus vulgaris. And I think it's difficult because there are different ways of sort of asking whether or not you know the difference between Pemphigus vulgaris and bullous pemphigoid, which are the sort of main differentials. The other stuff, so we talked about staphylococcal cold skin syndrome. You can have bullous disease, these sort of big sort of vesicles that can pop, certainly. And pemphigoid gestation is, as you can tell from the name, is more likely to be in someone who's pregnant. Again, there's no really indication of this. And the dermatitis herpetiformis is not really a sort of a bullous disease per se. It tends to be sort of an itchy red rash rather than anything. So let's talk about the differences between bullous pemphigoid and pemphigus vulgaris, and that will help us to distinguish between the two. So the way I remember it is that you both have sort of bullous disease, but pemphigoid, the D, is quite helpful, so it's deep. So actually you will more likely see that the blisters are intact because they're so deep. And then pemphigus is superficial, and because it's superficial, the blisters are very likely to pop, and when you see them, they're more likely to pop already. So that's how I differentiate between them, and a sort of relatively superficial mnemonic level. I like mnemonics. If you do, then this will be useful for you. So yeah, so they're both sort of immune conditions. The main differences, as you can see, if you were to look here, so BP on that top side, the bullous pemphigoid, you will see that you have deposition of IgG on the basement membrane. So you can see how it's sort of nice. If you go back to your histology days, or the nightmare that was your histology days back in the day, then you'll remember that this looks a bit like a basement membrane. Whereas in pemphigus vulgaris, here, you can see that sort of staining, so on immunofluorescence, is sort of throughout the epidermis rather than just sort of the basement membrane itself. And equally, this helpful image has told us as well that it's more likely to affect the oral mucosa. So if we go here again, so we talked about the IgG in the basement membrane. Deep blisters rarely affects the oral mucosa, and you tend to do a skin biopsy and immunofluorescence, and you tend to give very potent topical corticosteroids. The management, not so important, to be honest, at your stage. It's mainly about differentiating them because they're sort of quite a juicy exam topic, to be honest. The other aspect of this as well, just for reference, is that there's something called Nikolsky sign, which is a sign where if you were to put your finger right next to the blister sort of extends out right next to your finger. So it sort of reacts. And it's sort of a sign of the blister the sort of permeability of the blister, as it were, or its ability to extend. So it's a sort of useful thing that I suppose dermatologists use. I've never used it myself, but it's relevant to pemphigus vulgaris. And then, yeah, the treatment is going to be oral steroids, and it will affect the oral mucosa, as we say. And that's the mnemonic at the bottom: superficial pemphigus, pemphigoid, deep blisters. Cool. Fine. Next question. Okay, so here's the poll up. Right, so I think a few more people answer. Good. Cool, right. So get that off there. See what you think. Good. So I think quite even spread, I suppose, which is good because then we've got lots to learn. So so B is 25%, C is 29%, and E so 29%, and then D is 14%. So okay, which is fine. So lots of things to gain. Okay, cool. So sharing the results, everyone can see that, I think. So fine, good. Stop that. So got a 13-month old girl, and she has a rash that's getting worse. She's got red, dry, itchy patches affecting her cheeks, and the rash has become worse, and she's become tearful and unwell. Lots of vesicles on her cheeks, around her mouth, some of which have been ulcerated, and the small amount of yellow crust visible. So the temperature is 38. So I think just a rule of thumb, at least, maybe it's not so clear cut, but generally speaking, for me, when someone says in a question that there's yellow crust visible, it tends to indicate, although it's not a foolproof plan, it tends to indicate that there's some sort of overlying infection or something, and that's what we were taught, because you can have sort of certain conditions that you have overlying infections, and therefore you have this sort of yellow crust that comes out. The other thing that's really important in this aspect here is that you have vesicles. So vesicles are very particular to certain conditions, such as herpes viruses, and also ulcers as well can be particular to herpes viruses. So you could argue that perhaps there's a vesicle that's related to a herpes virus, and then there's an overlying infection, which is quite common. So the answer here is herpes simplex virus, which is common. So where you have this sort of underlying skin condition, for example, and then you could possibly get other stuff on top of it. So like a herpes virus, for example, and I'll show you the next slide. We'll talk about it in a bit more detail, so it makes more sense, because I think this was something that caused a lot of confusion, which is fine. So basically, what I was referring to is that you have this sort of eczema herpeticum, which is basically when you already, it sort of depends, because you can have different infections overlying different skin conditions, but there's a very sort of well-established aspect to eczema, where you have eczema, which is already sort of a bit dry, a bit red, and then on top of it, if you have herpes infection on it, then you got this sort of vesicles on top of it, and that can be quite distressing to especially young kids, and you sort of need to treat it appropriately, and you can also obviously make sure that there's no superficial sort of bacterial infection on top of it. So with eczema, you have dry skin, you have poorly demarcated erythematous patches. Importantly, it affects the flexures more than it affects the extensors, as opposed to in psoriasis, for example, which more likely to affect the extensors. And again, the same sort of principles apply. You're avoiding irritants, you're giving soap substitutes when available, lots and lots of the steroids, sorry, not steroids, the emollients, so make sure the skin is well moisturized and to avoid sort of cracking or drying of the skin. And then if things are really bad, you can give topical steroids, starting with a simple one like hydrocortisone, and you can work your way up with steroid-sparing agents such as tacrolimus, oral steroids, and then there are more severe elements that you can use, sort of phototherapy and biologics as well. As we said earlier, one of the feared side effects of eczema, which is very uncommon given that how common eczema is erythroderma. And of course, when you have people, we give people topical steroids, there's also a risk of sort of skin thinning around the area. That's why you sort of don't go for the very potent topical steroids. You start off slow at the weaker ones, and then you sort of build yourself up as you go along. Cool. So yeah, so in terms of nice guidance for atopic dermatitis or eczema, you have to have itchy skin, and then 3 or 5 of visible flexural eczema, history of that, history of dry skin, and you can also, because it's sort of atopic dermatitis, you can also have an association with other atopic syndromes such as asthma or allergic rhinitis. And then you can also use that in kids if they are on onset of less than 2 years old. It does sort of help, because it's a condition that can start in kids as well. And it can, of course, happen in it's more likely in pediatric patients, but also you can get it in adults as well, as I'm sure you know. So in any sort of age group. Yeah, cool. All right, so let's move on to the next question. Good. So okay, so last few ones in. Good. Right, okay, let's have a look, people think. So 69% have gone for C, cool. And then it's fine, okay, so people can see that, it's good. And that is the correct answer, I think. Is that right? Yeah, good. So you can sort of tell by reading the question, but also looking at the face or someone's top of the head with a hairstyle that is disturbingly like my own when I was about 13. So let's not talk about that. He has skin lesions over the forehead and cheeks worsening over the past couple of months, and basically it looks very much like these acne, which may be very familiar to lots of people. And it is described as sort of pustules or comedones, and it's fairly straightforward in terms of if you were to ask to describe it or to sort of identify it from an image. And then the question is, how are you going to manage it? And the first line treatment tends to be topical benzoyl peroxide. And then rather than go through all of them, let's just talk about the stepwise management of acne. So the disorder of the follicles tends to involve this bacteria, Propionibacterium acnes, and so some treatments therefore are antibiotics to try and reduce the load of bacteria in the skin. And it is classified into mild, moderate, severe, where you have comedones, subsequently pustules, and you can get scarring as well. That's considered severe acne. And then it's a mix of sort of trying to reduce the bacterial loads, but also you can reduce the inflammation. And also, as you can see, you can try the oral constitutive pill in women to try, and it has an effect on hormonal changes. It works in some people, it doesn't work in others. And then the sort of end stage, or the thing that people can use if the acne is severe, is you may have heard of Roaccutane, which is very important because to exclude pregnancy in women, because it can cause severe birth defects. In theory, it also has a effect on mood and has been linked to mental health disorders in the past. I'm not sure how strong the link is, but it's described, and I think it is strong enough that people do mention it. But it's by no means common, as far as I understand from my own dermatology experience. So that's acne for you, very common disorder, especially in the primary care setting. Good, okay, so last few questions, I think, and then we'll see what we think about this one. Okay. Okay, so we'll share the folder. What do you think? Good. Okay. So last few, I think most people have actually answered, so that's fine. So last two people. Good. So let's end that poll. So I think 66% have gone for A. We have 21% have gone for B, which is good. Let's have a look. So that is the correct answer. B. A. Sorry, yeah. Basal cell carcinoma. So you've got a slow-growing lesion. And he has had sunburn in the past, which is a very sort of obvious risk factor for skin cancer, as I'm sure you all know. And then looking at this lesion, sometimes they don't really give you that much information in the stem. They sort of just ask you to identify the image. And the key aspect here is that you have these sort of rolled edges, which is sort of very associated with basal cell carcinoma. whereas sort of squamous cell carcinoma may be more likely to be sort of ulcerated, although there is possibly some element of ulceration here, but you won't have those sort of rolled edges right on the outside, as you can see there. But let's talk about basal cell carcinoma in more detail. So you can see here that you have this sort of, the rolled edges we talked about, you have I suppose you do have a pearlescent appearance, a bit of a sheen there where you may not get in squamous cell carcinoma. You get telangiectasias around the side. I suppose in here, perhaps you can see some elements of telangiectasia, sort of like red dots there. And that is sort of more likely basal cell carcinoma. Age and fair skin and previous damage, and essentially you treat with excision, and in other cases you may do radiotherapy or cryotherapy or other more specialist treatments. One thing to know, just to know what it actually is Mohs micrographic surgery. In certain areas that are a bit more delicate and you don't want to excise too much, what you do is you sort of excise a bit, you put it under the microscope, and then you have a look at it and you see if you've got your edges not showing any evidence of the tumor. And then if you do have evidence, you then excise a bit more. So it's a sort of progressive way of excising more and more tissue, trying to spare as much tissue as you can. And we tend to use it a lot in the face, as it were, because it's a delicate area. But basal cell carcinoma, it doesn't have much metastatic potential, but can be locally invasive compared to the other skin cancers. So that's basal cell carcinoma. Let's look at the next lesion. So I won't give you too much time on this, so actually I'll start the poll. Good. So straightforward enough, I think. So put it all into your answers if you can. Where have we got to? Fine. Okay, so I think we'll stop there. I think most people put their answer in, which is good. So end that poll. Fine, good. So share results. I think 83% have gone for D, which is squamous cell carcinoma, which is the correct answer. I guess I'm sort of just trying to show you the differences. Really, realistically here, you can see, again, you know, it got a bit tender, bleeding, ulcerated, not really those rolled edges we saw, perhaps not that sheen, although obviously it depends on the camera that you're using, but equally, you don't have the rolled edges, and you don't have possibly not the telangiectasias, this big ulceration. Essentially, this ulceration there sort of should indicate to you it's more likely to be a squamous cell carcinoma rather than the others. Although you can have ulceration, of course, in other conditions, even in melanoma, for example. Fine. So you can get a nodular tumor, you can get a crusted tumor that can ulcerate, can just get ulceration. The main difference is it can metastasize outside of the skin to other places, whereas basal cell carcinoma does not so often. And you sort of get this spectrum of different degrees of carcinogenesis, as it were. So you can get actinic keratosis, Bowen's disease, which is you get these sort of red sort of patches that later on can ulcerate, and those can sort of be pre-malignant and then develop into squamous cell carcinoma. You can get it in previous transplant patients, so and particularly in your OSCEs, if you have a patient who you're looking at their skin and they have sort of these red dots, these could be actinic keratoses, which can be associated with someone who is immunosuppressed. So if you're on something like steroids, tacrolimus, for example, if you just see someone in an OSCE and they have all these like small red lesions, for example, you could possibly make the conclusion that they're immunosuppressed, and you then start looking for a renal or a liver transplant. But again, that is something that sort of you need to look at the whole picture as well. So yeah, you investigate with a skin biopsy, and then you treat similar to what you would do above for sort of excision-based therapies, but of course there are other therapies as well. And the mortality is low comparative to other cancers, of organ cancers, but if there are metastases, the survival is 25 to 40%. And so not as good as basal cell carcinomas. Good. Okay, so I think this is maybe the last one or two questions, so we can maybe wrap up. Can't remember, but we will let you have a look at it. Okay, let's get this polling up. Good. Okay, so let's have a look. So most people have got their answers in, which is fine. Let's have a look there. Share results there. So yeah, 68% have gone for A, and then 16% have gone for D, and 8% have gone for B. So I think a lot of people probably know what we're on about when it comes to this question, and if not, we will discuss it. I suppose this is one of the things that probably should have a very good knowledge about, because not only does it come up in exams, but also it is, you know, something that you will come across and you will be expected to recognize and act upon as a doctor. So the answer here is sentinel node biopsy. So you've got someone who we suspect has a melanoma. They've got an irregular asymmetrical pigmented lesion. We'll talk about recognition of melanoma, which is the most important thing, I think, when you're a doctor that sees lots of patients. And then their biopsy is performed, and there's a 2 millimeter breast low thickness. And basically, with breast low thickness, it is a buzzword. If you have more than 1 millimeter of breast low thickness, which is sort of how deep the tumor is, then you would go on to do a sentinel node biopsy. Because with the more than 1 millimeter breast low thickness, it is predictive of spread, and therefore you need to go looking in the lymph nodes in order to have a look to see if there's any melanoma there, because then it does change the treatment from a sort of simple excision to sort of more sort of whole body, not whole body, but sort of possibly regional whole body therapy. And therefore that's why you do the breast low thickness. And then it's sort of in your head, you should be thinking, okay, breast low thickness, more than 1 millimeter, sentinel biopsy, and it's sort of this buzzword that you'll keep in your head. That's quite helpful. Good. So with melanomas, the way to sort of look at them is to look at whether or not there's any asymmetry, look at the border, and then let's just look at the next slide so I can get it up. Sorry, it's, yeah. So you're looking for asymmetry, and you're looking for if the border is irregular, if there's irregularities in the color, if the diameter is greater than 7 millimeters, and also whether or not it is evolving and changing within time. Perhaps that also, that you can get that from the patient, probably won't be able to see it as much unless you have sort of different images. And so if it changes quite quickly, then that again is more likely to be a melanoma rather than just a sort of a mole in itself. Okay, and then what you are doing when you look at it, as we talked about, so you look at the dermatoscope, which is sort of a microscope type device that allows you to look at it in a bit more detail. You do the breast low thickness as we talked about, and possibly a sentinel lymph node biopsy, and then you may do other investigations to look for any sign of spread, such as a chest x-ray, a liver ultrasound, and CT, chest, abdomen, pelvis, which is sort of, we would use very common in patients who have cancer. So let's go back a bit. So melanomas are essentially a cancerous growth of melanocytes. It can spread anywhere in the body. This is a very particularly spread image. As you can see, it can metastasize, just to sort of remind you that the ability to metastasize is quite great. And then there are certain subtypes that you can have sort of precancerous growth, such as antigno, malignant, and you can essentially have it can sort of be superficial, it can look nodular, and you can very rarely have non-pigmented melanoma. But again, a bit niche, a bit postgraduate, let's leave it at that. And the risk factors are so having sort of moles, and so always need to make sure to watch any moles for any change of color or any growth, sun exposure, having fair skin, and as you might expect, a family history of melanoma can increase your risk due to a genetic element to having this condition. So the management, as the most skin cancers, sun exposure to try and reduce that, and wearing good sunscreen, and then a 2-week referral to dermatology as an urgent referral. 5-year survival is 73% and 85% in men and women respectively. And then you would consider doing a wide local excision with a consideration of removal of lymph nodes if it's spread there. And of course, you can have radiotherapy, and of late, quite good therapies are immunotherapies, which again, quite a specialist, but it's good to know that this is sort of the severe aspect. What you might consider in patients who, you know, can benefit from very good treatments if their cancer is spread. Cool. So I think that's us for today, right on time. So about an hour in. Focus, please, for going forward on perhaps the bullous pemphigoid, bullous pemphigus, erythroderma, Stevens-Johnson syndrome, and toxic epidermal necrolysis. If you have any questions, please feel free to email me. I think there's a feedback form perhaps going around. There we go. Please do that for me for my portfolio, because it's very useful. Also will help us to sort of change up the platform, the way that we do these lectures. And thank you so much for coming. If you want to come to our other lectures, we do them every week. Quesmed tutorials on our Facebook page. Also, we post them on. We post all the links on Instagram as well. And then we have daily single best answer questions that are free, of course, on Instagram. So yeah, feel free to join us. And yeah, I'll be giving another lecture, I think next month, I think is my own next one, but we do one every week. And yeah, please do fill out the feedback form. And I'll be here for a few minutes if you want to ask me some questions. So. Okay, so someone's asking, in the eczema herpeticum case, does the yellow cross suggest bacterial infection overlying, or is it due to the herpes virus itself? In this particular scenario, it's more likely to be related to the herpes virus itself, but yellow cross can also indicate bacterial infection in other instances. You're very welcome. Yeah, thanks very much for coming, guys. That was good. Enjoyed it. Dermatology. I think my specialist interest is neurology, but in dermatology is quite interesting because it has a lot of sort of relationships with different aspects of medicine. But yeah, cool. If there are no other questions, I'm going to head off. Perhaps we'll see you at our next lecture if you are available. And then I'll put the recording up if you want to look at it later as well. And yeah, thanks very much.
Thank you.
Thank you very much, Kate. We'll see you later.
See you soon.
Thank you. Thank you.